Hello. Good morning, everyone. Thank you so much for joining us here today. I know a few of you are joining us in for the first time, and my apologies for the kind of delay in us getting started today. My name is Rose Gold, and I'll be helping to host today's show. And we are going to be talking about the topic of Suicide Prevention Day, creating hope through action. I have some very wonderful guests that unfortunately I didn't have the pleasure to fraternize with before our show today due to some technical difficulties. But I would love it to go ahead and get started for myself and also for our audience. If everyone could just please go around and just state your name, what it is you do, and where you're practicing from in the world. And we can actually start with you, Dr. K, and work our way around if that's all right.
Sure, I'd love to start.
Thank you.
Hi, everyone. I'm also happy to be here and to get to know the panel and whatever's coming up from our audience. My name is Dr. Kay Hubbard. I'm a naturopathic doctor, and I also have a master's degree in clinical psychology. I practice in Los Angeles, California, but I have a virtual practice, so I actually see clients from everywhere, mostly Black and brown people from the diaspora.
Awesome. Thank you so much. Mr. Williams?
Yeah, so my name is Dante Williams. I am a licensed professional counselor, current doctoral student at Mercer University. Recent adventures served as the CEO for the Confess Project of America Now, and I'm currently navigating the market. I find, like Dr. Harbert, a lot of contract opportunities are coming in, so I'm just excited for what's next. Yeah.
Awesome. Thank you so much for being here.
Certainly.
Dr. Bruce Goldie?
Yes, hello. It's great to be here from England, and I sort of have my fingers in a few pies, but I'm a senior teaching fellow where we're working with young adults in training them to be education mental health practitioners. I'm also a text counsellor and just really interested in community projects, mental health, and just supporting the elderly, young people, different groups within our population. So it's great to be here today.
Awesome work. It's so great to have you. Thank you so much. And last but certainly not least, Mr. Gaines.
Hi. Hello, everyone. My name is Idris Gaines. I am an MSW and MPA. I am also a director of youth services for a behavioral health agency, and I oversee a juvenile detox facility and a juvenile residential facility.
Absolutely wonderful. Thank you all so much. It's so great to have you here, Mr. Gaines, with us, and all of you. It's such a pleasure. Again, I usually get a chance to speak with the guests a little bit before the show starts, but unfortunately, time did not allow. So thank you all for giving me and the audience just your background and everything that it is you guys do. Very important work. So our topic for today, as I kind of stated earlier at the beginning, is we'll be talking about creating hope through action, specifically in terms of suicide prevention. This World Suicide Prevention Day actually just came to be a thing in the States here, I believe, about maybe 7 years ago, if my research serves me correct. I'm not sure everywhere else in the world, but here in the U.S., it just became relevant in the last 10 years. Very important topic. Just to make sure that we're kind of on the same page in terms of creating hope through action in terms of world suicide prevention. Do you guys, and we can start again in the same order if that's okay. I guess my first question would be just in terms of suicide or suicide prevention. Do you see or do you work with that on a daily basis? And if not a daily basis, do you have maybe some own personal experience in terms of suicide prevention itself? And Dr. K, we can go ahead and start with you again and work our way around. And we do have another guest that just joined us that I want to introduce after this question, if that's okay.
Yeah, okay. Uh, so I don't work with it on a daily basis. I do work with mental health cases on a daily basis. So when I have a new client, I always screen about suicidal ideation.
Mm-hmm.
But I would say that my personal experience with it is that I've dealt with suicidal ideation in my own life. I've had siblings who have attempted, thankfully, no completions. Um, so it's something that's dear to me because I know how drastic it is. But when it comes to seeing clients, I do see it in the population of patients I treat, but I'm also usually working with anxiety and depression, and how that can dip in and dip out of SI, not always actively attempting.
Got you. Thank you so much for that. And Mr. Williams, how about you? Do you experience with clients on a daily basis with suicide or suicide prevention, or if not in your own personal life, has that shown up for you at all?
Yeah, certainly. So I would be remiss if I didn't acknowledge the whole panel and just the honor to serve. But what I will say is that I've had a lot of experience working with clients that were directly suicidal. I think one of the most pronounced experiences was serving as a crisis responder,
Mm,
protection and military crisis line. I've had the honor and privilege of serving as a clinical director for several inpatient and outpatient facilities,
nice.
oftentimes where we will encounter those who are suffering from suicidality. Yeah.
Gotcha, gotcha. So you've had that experience more so on the prevention side or when they're already at that point. That's
Yeah.
excellent. Thank you. Doctor, how about yourself?
Yes. When I worked with children who were excluded from school,
Mm,
within those centres, we would have those different behaviours, but also suicide ideation. I don't work with it on a daily basis, but I do text counselling. And
mm,
I've noticed that over the year, every week or whenever I am within those sessions, I'm always speaking to people who say, I don't want to be here, I want to die. And that's been a big difference over the year, because I know each week I'm ready to have these conversations about people not wanting to live. But I think we have young people as well texting in as well, so that's something that is, at one side you think it's a good thing because there is an outlet for people to start expressing how they feel, and then on the other side sometimes you can have young people from the age of 9 or 10 texting in.
yeah, absolutely. Thank you so much, Doctor. And Mr. Gaines, how about yourself? In your line of work, do you see a lot of that suicide prevention angles, or personally?
Yes. So dealing with the youth population, as many of you may already be aware, we're seeing a rapid increase in the rates of suicidality amongst youths. So
Very.
working with youth in substance abuse related facilities,
Mm,
that's an even greater increase or greater likelihood of suicidality. So we conduct regular suicide screenings and risk assessments, as well as just following up and assessing for trauma ACE
mm,
scores, and
mm,
going that route, making sure that we're really treating the those more exigent issues
mm.
that we may be facing,
Yes.
so we can then get to the other issues on the other end.
I love that. I love that. And that's actually a great segue into our next question. Just as far as that assessment piece and how kind of those ideologies relate to other things that might be going on. But before we go ahead and move on to our next question, I do not want to exclude or forget about a guest that just joined us. Mr. Noble, thank you so much for joining us on today. I apologize that there was kind of a late entrance of your profile into our panel interview today. But if you could please just go ahead and tell us what it is that you do, your name, what it is that you do, and where you're practicing from.
Okay, thank you everyone. Good day. My name is Alexander Noble, and I'm a mental health advocate. I'm practicing from Nigeria, and I basically deal with secondary schools down here, teenagers more. That's basically my field, advocacy and awareness.
Excellent, excellent. Thank you so much for joining us here on today. And just so that we could go head on, and we kind of already hinted toward this, but you guys brought up some really good points in terms of Mr. Gaines, kind of just piggybacking off of what you said, you guys, in your practice. how you kind of screen to try to figure out how those ideologies maybe relate to other things. So here's a question for the panel. And this time, Mr. Noble, we'll start with you and we'll go ahead and work our way up to Mr. Gaines. But the next question is going to be, in your experience, and this can be personally and professionally, what has been the hardest part about detecting suicidal symptoms or that suicidal kind of ideologies? What is the hardest part of detecting that, or maybe what are one of the hardest signs to kind of pick up on? Mr. Noble, I'm sorry to put you on the spot. You just joined us.
It's
Since you missed
okay.
out on the first few questions, we'll go ahead and start with you. What do you feel has been the hardest part, or is the hardest part in your practice of kind of detecting that?
Okay, because I deal with teenagers in a society that often doesn't give them opportunity to speak out, it's always difficult getting them to confide in you certain things. So you have to watch out for physical signs.
Mm-hmm.
That's basically, so it's been challenging getting teenagers to open up to you. The society doesn't give them opportunity. They're always relegated to the back when it comes to things concerning health, even mental health. And in school, many schools don't have a psychiatrist or a psychologist that attend to them. So they often deal with their problems themselves. That has been very challenging down here in Nigeria.
Thank you so
Yeah.
much. Thank you. I appreciate that, Mr. Noble. Dr. Hubbard, what about you? What has kind of been the hardest thing in your practice in terms of kind of detecting or symptomatic seeing that suicidal ideology? Oh, doctor, I think you may be muted. Thank you.
Muted. Thank you.
Oh,
I would say that my biggest challenge is that I work virtually.
okay.
So even though I'm dealing with adults who have chosen to come for me for some reason, so their goal may be,
Yeah.
be more involved in my life, whatever. Screening for SI, if they're uncomfortable with it and they don't want to share those thoughts, it's hard for me to see the shifts in their daily life. I'm like, are you always calling in from bed? Are you, is your self-care on par? But then I can't tell because they're not in public, they're in a home space. And maybe that's all they can do is to show up in that way. And it may not mean that they're suicidal, it may mean that they are. So I have to look for context clues, like what, are you being social? I have to ask other questions around it. If I'm intuitively getting something, I'll ask directly. And I hope that they're always honest with me.
Right. Absolutely. Very good. Mr. Williams, how about you?
Yeah, certainly. So I think for this, I have just two responses. I think as we talk about the hardest part of detecting it, looking at it from a clinical standpoint, I think it's really trusting your gut, right? And even from a family and friends standpoint, that something's wrong, right? And I know for me personally, it took a while for me to get to the place to where I could be comfortable enough to say that, yeah, man, this person may be suicidal, maybe having thoughts. And then I believe there's another hurdle that you have to get over, the fear of asking, right? So we know that research says that asking does not promote suicidology and so forth.
Right.
The other point that I wanted to make is largely to the clinicians. I think a sign that is often missed within suicidology is the drastic shift in behavior, right? So you can have a client who comes in, they're depressed, they're crying, and then all of a sudden they're happy and they're joyous. And we as clinicians can believe we did a great job, right? That we did our work, and that oftentimes can be a sign that the suicide risk is greater. Yeah.
Wow. That's very great insight, Mr. Williams. Thank you so much. Dr. Bruce Golding, how about you? What is kind of the hardest part about kind of detecting some of that suicidal ideology?
Yeah, I agree with everything said, and I think it just highlights the complexity or the challenge with working with individuals because we all respond differently to different things. So to actually say, for me, I think there would need to be some kind of relationship where you can see a shift in, as you mentioned, a shift in their behaviour, whether in the same vein that Dante said that it could be this excitement, that could be I've finally made a decision, I'm happy about that instead of being in this sitting on the fence, this turmoil. So
Mm.
I do think it's challenging to be able to say what exactly are those warning signs, because you can have the signs of hopelessness and feeling, but also the signs of guilt, because studies do say that those guilty feelings
Yeah.
over a prolonged period of time can also lead to suicide ideation.
Yes.
So I do think having that communication with someone and just the space to even talk about it, because even working with other professionals, sometimes it's very difficult to even say the word suicide,
Yes.
alone let's talk about what you're actually thinking in your mind. So I think on a bigger scale, we need to be able to have spaces where we can talk about suicide, and young people, adults of different ages and backgrounds should have that space to be able to talk about those thoughts and feelings.
Absolutely. Thank you so much for that, doctor. That's great insight. And last but certainly not least, Mr. Gaines, how about you in your line, in your field? Kind of what are the harder symptoms or the harder things to detect about kind of that SI?
And I'm definitely going to have to agree with the entire panel that this is very complex.
Yeah.
And what a big factor is also stigma.
Mm.
A lot of people don't want to, say, yes, I'm dealing with suicidal ideations, because they
Yes.
don't want to be deemed as crazy, or that they have a problem.
Right.
So stigma is a very big barrier to actually getting the care and getting the access that you need to appropriate and quality mental health services.
Mhm.
Another big barrier is the fact that we have a very fragmented system of care. A lot of the early touch points. So for kids, those early touch points are in school.
Right.
The school system, the teachers, the guidance counselors, those are the individuals that know or should know these kids, and would
Mhm.
be able to pick up on those things and should be able to connect them to the most appropriate mental health provider, most appropriate community mental health system. However, because our system of care is so fragmented, that does not always happen. So by the time they come to, like, let's say my facility, they're already at the point where they've had a long history of suicidal ideation, or
Mhm.
they've had a history of intensive mental health needs. So you've got a lot of complex barriers, and stigma being one. That's a big factor to
Yes.
be able to address, to actually meet that need.
Absolutely. Absolutely. Thank you so much, you all, for sharing. That was some very, very, very great insight. Now, I know that our show is called, Black Mental Health Matters. And of course, we are definitely, our services and our show is open to all people. But this question is going to be specifically about your experience with our Black and Brown races, as well as other races that I'm sure that you guys all work with, right? Do you, in your experience, um, do you feel or have you seen that the different symptoms of SI, or maybe the different reasons for SI, I should maybe say, does that seem to vary by race in your practice? And let's see, Dr. Bruce Golden, we'll go ahead and start with you. Then we'll do Mr. Williams, Dr. K, Mr. Noble, and then we'll end again with you, Mr. Gaines. But I promise you, you're coming. Your turn is coming first in a few. But Dr. Bruce, I'm curious to hear from you. Does the SI vary by race in your practice?
Well, I would say over the years, and just even looking at studying the history of suicide as well,
Mhm.
I would say within our communities, you've got religion that can be, it can also be a protective but also a risk factor, where
Wow.
if somebody is experiencing suicide ideation, they may be told to pray or go to the mosque or
Mm.
and
Wow.
the other levels of support are not brought in. So I think there are, and also the guilt. If somebody is torn, if you have, when we look at intersectionality, you might have a black male who may have a different sexual orientation or different, all of
Mm.
these different um, factors can impact on whether they're going to talk about these things, the internal guilt that they experience, but also how the community will treat them if you fall out of that traditional way of being. And I'm not saying it's every community, but I think that can happen. I think we're on a journey, because I've been to other, spaces where they are, particularly Black and brown spaces, which do talk about the lack of spaces to be able to share about suicide ideation or just mental health, because it's not always recognised or acknowledged as something where other levels of support may be needed. But also, there's the racism experienced through professionals who don't know how to support Black people and Black and brown people with cultural differences there as well. So I think there are a lot of factors involved in it, but I do think within our communities, I think things are changing, but even saying the word, that someone feels very guilty about thinking it, but also saying that word, suicide. So yeah.
Absolutely. Thank you, Doctor. That certainly was some very insightful information, and I definitely agree with you. We do know, just all of us here are mental health professionals, and as we kind of look at the history of kind of the mental health field, how it originally did have a pretty much European based, right? And so when you said that, it kind of gets difficult, or it kind of gets blurry, where there's a lot of professionals who still do not know how to address those issues within the Black and brown community. So I just wanted to point that out. Thank you for saying that. Mr. Williams, coming to you, in your practice and in your experience of working with who you work with, do you find that kind of those symptoms or that those SI traits, does it vary by race in terms of what you see?
Yeah, so I would say absolutely, and I'm going to try not to get in trouble with this question.
No, feel free. Be free, my friend. Be free.
Yeah, so I think absolutely. I think when we look at the Black experience, right, we understand that there are different social determinants of health that impact communities differently. I think when you look at the systemic and the intentionality of, certain political race, groups and things of that nature, the experience is very much different, right? We're looking at poverty, we're looking at trauma, in different veins, and then also I think just the notion not to speak about it, right? And I think we're overcoming that, as Mr. Gaines pointed out, as it relates to stigma.
Yes.
And then just two other quick points. I think that it's a conversation around access, right? Within the Black community. How do we increase access and things of that nature? And then also diversifying the mental health space, right? And so there is not that other races can't do the work and that they can't be culturally informed, but there is a need to have more clinicians of color in service. Yeah.
Agree. I totally agree with that, Mr. Williams. For myself, it's myself and maybe one other woman in my building. So that is a person of color. So I definitely hear you what you're saying. Not to take away from any other race and their capabilities, or certainly, like you said, their cultural competence. Not doing that, but just saying there is a need in that space for more Black and brown clinicians and people that can do the work. So thank you for that. Dr. Hubbard, what about you in your practice, especially with you working virtually? Do you see that the SI, or maybe the symptomatics of suicide, does it vary by race for you?
Well, I'll be honest and say that I've never had a person who's not Black or brown have SI in my practice.
Gotcha.
So from personal experience, I'm going to say maybe.
Yeah.
And of course, it's my preference to work with the population that I do.
Right.
And I was trained on everybody, but it didn't come up. I will say that we're still taught based on the European model, because we're still taught that white males are the most likely to experience and complete homicidal ideation or suicidal ideation. And there's this caution that's built into even very new clinicians that we're supposed to pay attention to that.
Yes.
But I would say symptoms with my population clients, Black and brown, stigma does ring true, just what Mr. Gaines and Mr. Williams have been saying. I've heard stories of people who, oh, I have an uncle who maybe that's what happened, but they said it was a shooting and the police ruled it one way, but the family doesn't acknowledge it. They just never found the shooter. Not to bring gun violence into this because that's a whole.
Yeah.
But
I see what you're saying.
Yeah, there's definitely a discounting of what it could be or what could have brought someone there. People don't want to feel the potential guilt for not having recognized those symptoms in someone who's in their family, so they just act like it's not a Black thing. Black people don't do that. That's a white people problem. But it's not.
Right.
Yeah. I think it also slices differently with different generations as well, as far as who's willing to open up about it.
True. And Doctor, you made a really, really great point in terms of, mental health. And we talk about this actually a lot on this show, how just mental health as a whole can kind of be seen, or mental illness even, it's just seen as kind of like a white thing, or, that's for white people. Black people don't exist. And it's the same with suicide, especially as we all have experienced in some type of way the trauma of the COVID shutdown, and how suicide rates certainly did increase. There was a lot of there was a study that came out in the state of Minnesota in the U.S. about how, I think it was something along the line, I know it was over 25% of suicides are actually covered up as like by the family's request as like accidental deaths, like overdoses, things like that. So I just really love how you pointed that out, Mr. Noble. And this is going to be interesting because I know that you work in Nigeria, and that's predominantly right, brothers and sisters that look like us. Do you see kind of in your practice how the variations maybe in people who are maybe not immediately from Nigeria, how that kind of plays out in terms of the symptoms or the systematics around suicide? Is there a difference for you there? Oh, Mr. Noble, I think that you may be on mute.
I have to lose my mind. Sorry about that. Okay,
problem.
basically down here in Nigeria, I work predominantly with Blacks, and like Dr. K said, mental health is not a Black thing. That's the belief around here.
Okay.
Many people believe that is a white culture. It's not something, but in reality, a lot of Black people are suffering from it. But we live in denial down here. Yeah, many Africans, especially here in Nigeria, live in denial because of the culture and the society at large. So yeah, there's a difference. I noticed there was a spike in suicide rates in Nigeria shortly during the COVID-19 lockdown, 2020 down to 2021. There was a spike in COVID-19. We recorded over 40 suicide rates amongst young people.
Wow.
So it was something we look at for. Now, the problem we have here in Nigeria is record keeping.
Okay.
Many situations are not documented. Many of these things are not reported. Many cases are not reported. So what is supposed to be recorded as suicide is recorded under another cause of death.
Gotcha.
And that's a problem. That's a problem. So we can actually say this is the statistics of what Nigerians are suffering, and this is what it is. But in my experience working online, I've come to see that we have more of it in the white culture. It's more of the white thing, not the Black. It's more among the white people, because I also do some awareness online. I get some people of other races talk to me about it. Most times they share statistics of their family experiences with suicide and all of that with me. So more of the persons I've spoken with online that share their suicide figures with me, I realize it's more about the white people than it is than in the Black community. So I think, there is actually disparity among the culture, white and Black. There is.
Absolutely. Thank you so much for sharing that, Mr. Noble. And last but not least, Mr. Gaines, tell me your thoughts in your practice. Is there a difference in terms of the SI rates, or the symptoms around it, in comparison to race, in your experience?
Definitely. Symptomology is going to be quite diverse, and it's going to range not only amongst the different races, but within the race and within age groups. That symptomology is not to look the same. And then you also have to realize that for Black people in particular, there's less of a likelihood that they are going to leave some type of note indicating that they wanted to commit suicide or that they committed suicide versus their white counterparts. That's why it's much easier to ascribe their deaths to suicide for their white counterparts than it is to Black people or their Black counterparts. So you have to look at the differences in which those symptoms are presented. But then not only that, you also have to look in the differences in which we are able to diagnose. Because unfortunately, that whole system of diagnosing, it's very much based in Eurocentric viewpoints, and it's very much based off Eurocentric research. So it doesn't take into account, cultural differences. It doesn't take into account the racial differences or racial disparities. But I would say one very good point that I've noticed within recent years is that popular culture, TV shows, entertainers, artists, they are more apt to talk about mental health, to talk about serious mental illness. You see it in things like shows like Insecure, which is hugely popular within the Black community. There are shows like I May Destroy You with a big Black leading actress where they talk about traumas and they talk about going into treatment and they talk about therapy and just talking amongst themselves like, yeah, I go to the therapist, my therapist is great. But what's important though is that representation in that clinician, having clinicians that are culturally representative of the group that they are treating goes a long way with being able to actually address any of these issues, whether it's suicidality, homicidality, serious mental illness, any of those things. It's important to have that cultural representation because they can pick up on those cues, those small, tiny cues that we do every day when we're just talking to our friends or loved ones. So I don't think that can be discussed enough, really.
Absolutely. And you made some very, very wonderful points, just in terms of how it's not only the disparities and looks different amongst different races, but also age groups. So I think it's really important to take into consideration all of those different types of demographics when working with the group. So thank you for that. You really made a very interesting point with that. So let me ask you all this. I have another question that I want to submit to the panel. What are some signs? And I know that there's a lot, right? Because we all kind of know that there's a few things. But if you can just give me two, if you can give myself and the audience just maybe two signs that you can look for, not even on a clinician level, excuse me, family, friend, boyfriend, girlfriend, husband, wife. If you can give me two symptoms of someone who may be thinking or considering suicide. And we're going to go ahead and start with today, Mr. Williams. We'll start with you. We'll work our way up and we'll end with you, Dr. Hubbard. Okay. So Mr. Williams, can you give me two?
Yeah, I think from my experience, what I've seen that tends to be true and something that we all can relate to is just a prolonged depression, right? Particularly after following grief and loss. I think that that's very true, and even in addiction. The other thing I would also add is just that second sign is really giving away pets.
Wow. Never heard that one. Wow.
Yeah, what I found in my experience is that pets are really important, to people. And when you start to see anyone giving things away, it can be an animal, it can be things that they really cherish, that can be a true sign that there is a suicidal risk.
Wow. Thank you, Mr. Williams. That's brilliant. I actually never have heard the pet one before. So thank you. Dr. Bruce Golding, how about you? Can you give us two signs or symptoms of someone who may be having suicidal ideas? Excuse me.
Yes, I mean, a few things come to mind. I think about gambling. That also is, especially in the UK, there's a lot more campaigns now because we find that gamblers are high risk of suicide ideation. So a lot of
so sorry to interrupt you. Give me
Yes.
one quick second here. It sounds like we're having a little bit of interruption on our sound feed. Give me one second here. I really just want to make sure that everyone is able to hear what you said, because you also just said something that I've never heard before, which is the gambling piece. So just give me one quick moment here, and I just really want to
Yes.
make sure. Can you say something for me,
Yes.
Doctor?
Yeah. Is that better?
Perfect. Thank you
Yeah.
so much. Can you go ahead
Yeah.
and start over for me? I'm sorry, please.
That's all right. There's been a lot of organisations, like gambling organisations, who have become aware through studies and also just through seeing what's happening when people are gambling.
Wow.
They can be at risk of suicide ideation, and even
Wow.
when I do my text counselling, I might get people who do contact and say, I've lost all this money, I don't know what to do, my partner doesn't know about it,
Mm.
and then they're in a position. So gambling there's a lot more research out there now
Wow.
on just the effects of gambling on mental health, but also on suicide ideation.
Wow.
And then other symptoms could be dramatic changes in mood, but dramatic changes in appearance.
Oh.
So sometimes it's those things where you go to someone's house, or there could be lots of signs jumping out at us, but sometimes if we're not aware of the signs, it could be alcohol bottles, or it could be things not being washed up, it could be beds, it could be smells in the house that someone's not looking after themselves. Sometimes that also could be a symptom of suicide ideation, or just, as Dante mentioned, in just that level of depression where the self-care goes down.
Yeah, absolutely. Wow. Thank you for sharing, Doctor. That gambling one is new to me as well. So thank you. I just love learning new things. So thank you for sharing that. Mr. Gaines, how about you? Can you give us two maybe symptoms or signs of someone who is having those suicide ideations?
Wow. And you know, the panel, they've already discussed quite a few of the I see in my professional experience. I would, I'm not sure there's too much I can add to that, other than you just really want to be mindful of when you're dealing with a person that seems to have a loss of enjoyment in
Mm,
life for the things that typically do bring them joy.
okay.
If all of a sudden they're not able to find that same sense of, you know, joy, like let's say they love to play tennis and they don't love it anymore, or
Okay.
there's just this change where a lot of the things that they typically like doing, have fun doing, they just don't want to do anymore. And it just seems like there's that loss for them.
Mm,
That could be a good indicator
yeah.
that there are some suicidal ideations going on, or there's some type of mental health related issue going
Yeah.
on there for them.
Absolutely, and I love how you point that out, because a lot of times, right, we have the mental illness symptoms, and then we have the suicide ideation symptoms, and sometimes they can look alike. So, but you
Yeah.
just what you saying, just being mindful, I think is very important. Just being mindful of those different types of things. So, thank you for that, Mr. Noble. Can you give us
Yeah.
maybe you give us two in your area that you see that is kind of two symptoms that someone maybe is having those suicidal thoughts or ideations.
Okay. One of the major symptoms I've seen here is people taking into negative lifestyles that have harmful impact on their lives and not minding the consequences. So
Okay.
you see someone taking into lifestyle, they know this is harmful, this is going to hurt them in the long run, but they don't care about the consequences. Even when you try to talk to them about it, they just say they don't care anymore. That's a major thing I've seen around here. Then
Okay.
the second major thing I've seen is they take into dark arts. Most of
Mm,
them begin to talk more about dark arts, more about the afterlife. They don't care about what's happening in reality anymore. So they're just so concerned, so focused on the afterlife. Something you just have to look at for those kind of signs. They're more in tune with dark arts. Every music they listen to is all about darkness. The art, everything they do, just focus on that area. It's a sign we have to watch out for. I've seen that a lot around here. It's a major sign. Those are the two common signs I've seen here.
wow. That
Okay.
dark arts one is really that one is one that I've never heard before, but it makes so much sense just in terms of them kind of diving into that kind of life, or even the deep curiosity about it. So thank you, Mr. Noble, for sharing that. And last but certainly not least, Dr. Hubbard, can you give us two that you kind of see or have heard in your own experience about kind of someone who's having that those suicidal thoughts or those suicide ideas?
Yeah, we've definitely covered a lot of them
Yeah.
already. So thank you to the expert and educated panel.
Yeah.
So I'm gonna say the pets one I just clocked recently.
Wow.
I saw, this is just gonna be an anecdote, but I was on Instagram. There's a local fashion designer that I follow,
Mhm.
and he was selling all of his things that he used to make fashion. And I was like, kind of odd. I guess he's switching up, going to be creative in a different way, be a painter or whatever.
Yeah.
And he said, I'm also going to rehome my dogs. And I immediately went into his DMs and was like, are you okay? Like,
Right.
and the whole community was very concerned, and he was able to express that wasn't what was going on, but it was a huge red flag.
Yeah.
Sometimes I still think about it. I mean, this was last week. So like, let me go check. The other thing I want to point out is I think a lot of what we've been talking about is people who are new to suicidal ideation. It's a new thought, but there are people who live with it for years and it becomes their normal.
Yeah.
And then it becomes the normal for people who interact around them.
Wow.
And so I think the change, as if they had made a plan or were going to enact a plan, would be like a weight lifted off of them. So you have to, so sometimes it's like they no longer have joy and they're new to suicide ideation.
Right.
And then sometimes, oh, you know what? I'm finally done with this. This is exhausting and I feel much better. And so that's something.
Thank you so much. Oh, I just love this panel. Thank you guys so much. This is really giving me value, not only as a mental health professional, but I'm sure our audience as well. Let me just kind of switch it a little bit. Just in terms of those that are around the people that may be having these experiences, and I know that we're getting ready to close, but I have a few more questions that I think are very, very important that I really want to get out. How do you guys see suicide, or let me say this, do you think suicide prevention can be implemented in the workplace? And if so, what are maybe one or two things that you think the workplace can maybe implement for suicide prevention? And if you don't think that suicide prevention can be implemented into the workplace, why not? And Mr. Gaines, as promised, we'll go ahead and we'll start with you and we'll work our way down to you, Mr. Noble.
Wow, that's probably like the toughest one to start off with.
Sorry.
But yes, I do believe suicide prevention can be implemented in the workplace in a number of different ways. One big way is for employers to increase the level of benefits that they have when it comes to health insurance coverage. By adding mental health to that insurance coverage, you then create a better means of access for your employees to actually get the services that they need. That's a very big factor right there.
Yes.
But then also encouraging, not just paid time off, but having time for mental health days, including that as a benefit as well to employment and working at your company or agency. Though those two pieces alone would go a long way with being able to prevent not just suicidality, but our suicidal ideations, but also being able to address just mental health by itself. If you gave your employees greater access to mental health via your insurance coverage, and if you increase, not just paid time off, but hey, mental health days for you, where you could take them, one or two every 90 days to just be able to take a step back and recoup, that would be a very big factor. Some employers, they do try to provide basic health awareness for their employees, and they do discuss those things in a very general way when they talk self-care,
Yes.
self-efficacy, you know, and get and employee advocacy programs. So they talk about it in a general sense, but they really need to name it and claim it essentially. So when they name it and claim, you can really target it and
Mhm.
get to the nitty gritty of how can we actually impact these numbers? How can we actually increase our workforce and retention? And I think that goes a long way. If you hear all these Fortune 500 companies always talking about we can't retain employees, we can't hire new employees, well, hey, guess what? How about you do some things that would make a big difference by, you know, providing better benefits? If you
Yes.
can't increase the salary, if you can't increase the rate of pay, you know, do something extra with those benefits packages then.
Absolutely. I love that. And just wanted to say a quick thing. Kind of in the HR world of things, they have recently just started doing like the EAP thing where the employee assistance programs with mental health and things like that. But it's not something that's expressed. It's generally something that you have to call your insurance company and get insight about. So I just love how you mentioned if you do have these benefits, then make sure that your employees know about it. I love that, Mr. Gaines. Thank you for that. Dr. Bruce Golding, so for you, do you think that suicide prevention can be implemented in the workplace? If so, how?
Yeah, I think education, psychiatric education.
Doctor,
Um,
I'm so sorry. Give me one
here,
second.
I'm funny again.
It is sounding funky again. Give me 1 second here.
Okay,
Just
okay.
gonna see if there's just a little sound here. Oftentimes it's our program with the distance and things like that. Give me 1 second.
Yes, yes. Is that better?
It's absolutely perfect. Please
Okay,
continue.
I'll be quick then. So,
No, you're fine.
the first things that come to mind is education, and I think if we have suicide prevention education for employees, and if their family members and their workmates, they will be more attuned to the differences or being able to see the signs.
Yeah.
So I think the idea of mental health should be something that we is a normal thing, that as Idris mentioned, it's normal to take care of your mental health. It
Yes.
should be normal for the employer to be aware of their actions and the amount, you know, the work strain. It should be normal for a employee to be able to say to their employer, I'm struggling, without them thinking that I'm going to lose my job, or the employer is going to mark me down, or this is a sign
Yes.
of weaknesses. So I just think the levels of understanding mental health it's just so wide, because you're looking at societal views of mental health that can filter into the organizations and how they see mental health, and then the one-to-one relationships. So I do think through any form of education, psychoeducation, informal community education, so
Yeah.
that we all are aware of what mental health looks like in our own communities, and also in our other communities as well around us.
Yes. Absolutely. Thank you for sharing that, Doctor. And Mr. Williams, what about you? Do you think that suicide prevention can be implemented into the workplace? If so, how?
Yeah, so I'll say this question took me to a lot of different places, so I'll do my best to be focused.
Okay.
Um, so yeah, I think that it can be. My thoughts is that we need leaders to lead. Having worked in the industry and seeing different economic structures, I do believe the money is there. Why are we not paying the therapists, right? If they're
Right.
they're doing the work. Um, yeah, and I think even in the moments of crisis, after a suicide completion at a workplace, it really takes leaders to stand up and lead, right? And
Yes.
to put in the wellness initiatives and everything that's needed. And then just secondly, I think wellness. I think that we're in a time in the world where we have to focus on wellness. Hopefully this blesses some employee, but we need massage chairs, right? We need access to a gym. We do
Yeah.
need a mental health day, once a
Yeah.
month, twice a month, whatever works.
Yeah.
So my hope is that the times are changing and we can answer the call. Yeah.
Thank you so much for that, Mr. Williams. Dr. Hubbard, how about what are your thoughts? Do you think that suicide prevention can be implemented into the workspace? And if so, how?
I absolutely do. So just for those who may not know, the training for a naturopathic doctor is all about figuring out what the root cause of a situation is and addressing the root cause. So it's a lot of lifestyle intervention.
Yes.
And I say that because I think when it comes to the workplace, a lot of times purpose is what's lacking for people.
Wow.
And a lot of the work I do when it comes to, I guess, supporting someone in moving away from SI is, okay, well, for what purpose are you still here or would want to be here, or what would motivate you? Like, it's that type of thing, not so direct. And I think work is responsible for that.
Yeah.
I mean, we live in a society that's very navigated around, well, what do you do? Is that who you are? That doesn't have to be the case for everyone. So there can be workplaces that open up to really allow for people's creative energy to flow, regardless of what the space is. And regardless of, maybe it needs to be a hobby because of what your job is, but where are you finding that passion and how are you fulfilling it is really important. And I think that workplaces could do a much better job of realigning what the company's vision is with what their workers' vision is.
Wow. Absolutely. Thank you so much for sharing that, Doctor. You brought up a very, very interesting point as far as how the identity, it used to just be, in certain parts of the world, but now as a collective where we are literally identified by our work and what we do. So that was a very, very strong point that you made in terms of making that connection to how now can we shift that to being a place of help. So thank you. And last but certainly not least, Mr. Noble, do you think that we can kind of implement suicide prevention into the workplace? If so, how do you think?
Absolutely, yes. We can do that. We can implement suicide prevention in the workplace. And one of the ways is we come to work. I know it's called workplace. And all we do is talk work, work, work. I think most companies' goals, visions, they are driven towards a company's perspective, not employees' perspective. So I think companies, organizations need to have in their visions, in their goals, things that are tailored towards the employees, because the employees' well-being will also help drive company goals.
Right.
Yeah, that's one way. So let's talk about health, not just health. Let's address the different areas of health.
Right.
If we're talking mental health, let's talk mental health. If you're talking physical health, let's talk physical health. If we're talking emotional intelligence, let's talk about them, not just generally health, health, health. It doesn't cut it. It doesn't cut it. It doesn't do justice to every aspect of health. So employers need to look at their employees and address their health specifically, and not individually now, but have things that cover the different areas of health. Should have programs annually. It could be annually. Let's talk about mental health this period of the year. Let's talk about this aspect of mental health. Programs like that should be inculcated in every company. That's what I believe.
Absolutely. That is a really, really, really great point, Mr. Noble. We all of us, I'm sure at some point or even now may have worked in a corporate setting, and they have those little employee surveys that come out, right? But they're rarely to do about you. They're mostly to do about how things are running at the company. So I think, like you said, Mr. Noble, implementing, kind of having those conversations about the specific aspects. Okay, if it's mental health, let's talk about our mental health. If it's our physical health, let's talk about our physical health. So that you make a very, very great point with that. Now my next two questions, they kind of tie into one another, but I am going to ask them separately because I am interested in hearing the panel's thoughts on the two questions separately, and then we're going to get ready to close after these two questions. But recently, in the last few years, we all know how COVID has affected the world, right? The Tyler Project, which for our audience or some of our watchers or viewers or who may not know, the Tyler Project is a suicide study that they do. I believe it's every year or every 5 years. I apologize for not getting that right, but it is a study of suicide, particularly within the LGBTQ community, but it's focused on all. And it is a collective of teens. that they young adults, I believe the earliest age is 13. I believe the highest they go is 17, somewhere around that age range. Please Google the Tyler Project, because I'm sure I'm getting it wrong. But I'm interested to know, and I would like to start with you, Dr. Bruce Golding, and we'll work our way down to Mr. Williams. But how do you think, how let me see how I should frame this question without asking you two questions in one. What are some ways that you think a parent can speak to or talk to um, their child about suicide? How can a parent instigate or begin that conversation? And do you think that there's a certain age limit, or maybe there's a certain age where it's too early or too late? How do you think that conversation should go with a parent talking to their child about suicide?
Yes, I think that can be challenging. But I also think that it's important for parents to reach out to networks
Mm,
that are specialized, especially if we're looking at LGBT communities, and just how, one, it depends on the relationship that the parent has with their child, and
yes.
the openness that they feel, that young person feels that they can be open. So I think you've got the parent aspect, but you've also got, what are the sources? If you can't talk to me, can I provide any other sources for my child? And not seeing that that's a failure on the parent's part, but sometimes it's that growing up dynamic where a young person may feel guilty or feel like they don't want to upset their parent by saying, yes, I
Mm,
am thinking of taking my life.
yeah.
Because they know already that they will have burdened their parent, or they will see the facial response, and the parent may not know how to accept that, because
Right.
sometimes it might be then, I'm not a good enough parent. The focus then comes off that
Yes.
the needs, and then what have I done? You have everything. How ungrateful,
Yes.
it's turning into something where it's not intended. So I always think, wherever possible, for parents to seek advice, and but also get resources. That I know, if you can't talk to me, is a helpline, and let me know how I can support you and work alongside you. So I think it's a really sensitive approach, and I think if parents work together, and almost seeing that I think it's a change of mindset, understanding that the child might not think the same way as the parent, and
Right.
that is okay, because they are an individual thinking that of their own things. So I think there's a lot within that question, but I think it's that realization first, that their child is an individual person, and they will have their own thoughts on the world as well. So
Absolutely. Thank you so much for sharing that, Doctor. And I just want to say, because I know that we're getting ready to run out of time shortly here, but I really want to make sure that everyone has a chance to express their selves. And I apologize, you all, for keeping you past the time. But Doctor, you said something so profound when you said that how sometimes conversations about suicide can switch, right? I know that in my community, especially, if you go and you tell your mama or your father that you want to kill yourself, or that you are having thoughts about doing it, the average Black American parent, I can only speak for myself, will tell you, I do it, go ahead, I'll see you when you're dead. I'll see you when you're dead, and we'll figure it out, not meaning to come off so brash, but that's generally their response to it, because it doesn't seem like a serious thing. And so when you say, having, parents should maybe seek those resources if it's not a conversation that they're ready to have, or maybe even educated enough to have about the topic. I love how you said that. So thank you. Mr. Gaines, how about you? What are some ways that a parent can instigate that conversation?
Um, that is a complex issue. What one it has to be very age appropriate, and if you create an environment in which your children are safe to come to you and discuss these things with you, so you create that sense of safety for them, then it becomes much easier to have that conversation. Because one, it's talking about death with your kids. It's important to keep it simple,
Yes.
straightforward, and keep it honest. Don't use euphemisms or this person went to a better place or anything like that. You just keep it very straight, very simple. And then I have to agree, like, in the Black community especially, that's not something that we generally talk to about our parents, because Black parents, they kind of see their kids as like, oh, okay, we don't talk about this, we don't discuss this.
Yep.
Let's just end this right now.
Yes.
So it's being able to have that understanding that, what, this might not be a conversation that I am equipped to have with my child, but you know what, I know that there's this community agency. I know that there's this group that my child and I can go to together, not just sending my child there, but we can go to together as a family. Because the other end of this is, sometimes parents will, and they'll say, oh, I'm gonna send my kid to therapy, but that gives your child the message that, oh, there's a problem with me.
Right.
As opposed to, let's address this as a family, because we are here to help and support each other and one another. So it's like, you got to address that. And I know you brought up that LGBTQ issue, and there's a lot in that as well that also has to be unpacked when addressing, especially in Black and brown communities.
Especially. And Mr. Gaines, thank you so much. I just love how you said the action of doing it as a family, like sending your child, that the kind of message that's seen. That's not something that we actually talk about a lot in our communities, but it's a very important thing. Tackling the issue or tackling those ideologies about suicide together, even in mental illness, tendencies, we can do that as a family and as a unit. So I love that suggestion very much. Mr. Noble, what about you? What are some ways that a parent can instigate that conversation with their child about suicide?
Okay, sorry, Nigeria here, that conversation is never going to happen. I'm sorry. I'm sorry, but that's just a fact. It's never going to happen. No parent here will want to hear, I'm thinking about committing suicide. It's like, you're not serious. That's it. The parent would virtually walk out of you. But here's the thing parents need to understand. It's not about you. It's about the child.
That's right.
It's about the child. Now, the first thing you need to understand is, if you don't listen to the child, if you don't have that conversation, and anything goes wrong, you're going to lose as well as a parent.
Yes.
You're never going to be able to forgive yourself.
Yes.
Now, you had a chance to change something, to do something better for your child, but you did not, because you have a certain mentality that is not in line with the child's mentality. Right. You need to understand that first, there is an age gap between you and the child. So the way you see things will not definitely be the way the child will see the things. For you to understand the child, you need to have that conversation. And you need to have that conversation not from your perspective, from the child's perspective. That's one way you can address this. So it's never going to be about you as a parent. Parents should understand this. It is a child coming to you. For a child to come to you to say, I want to have this kind of conversation, it's a serious matter.
Yes.
It's a serious matter. You need to take it as serious as that. And that's where parents get it wrong. Dismissing such conversation, it's terribly wrong on the part of the parents. Have the conversation with the child. Allow the child to express themselves. Don't interrupt. Do not interrupt the child. Let the child say everything they want to say, no matter how dumb you think it sounds, no matter how bad, how terrible it sounds. Let the child exhaust themselves. Then you can pick it up from there. It's an important conversation we must have in the Black community. Enough of this, it's not a Black thing. Right. It's not a culture. We can have that conversation. No, people are dying from it. The figures is going up every day. We need to have the conversation, and it should be from the child's perspective, not from your perspective as a parent. That's it.
Thank you so much, Dr. Noble. You made a very, very good point. I hope that the conversation begins to happen in Nigeria with things like this, with these types of shows, with educators such as yourself, kind of bringing this awareness to your communities. So thank you so much for sharing that. And Mr. Williams, certainly not least, but what are your thoughts? What are some ways that a parent can instigate that conversation with their child about suicide?
Yeah, I think first, I want to acknowledge that we are all broken, right?
Mhm. Yeah.
And that we have to do the work, right?
Yeah.
And so we have to go to counseling, we have to heal ourselves. And I just want to put that out there as I identify what I believe are 3 points. And really, I think the panel has already hit on them.
Mhm.
So I'm just going to put them in my own words.
Yeah.
I believe that we have to be honest, right? As parents, we have to be honest that we're afraid to have the conversation. I think that our children need to see that fear, right?
Mhm.
I think that it helps the process to a certain extent. I also think that we have to mind our reactions. I remember in
Mhm.
particular, and we
Very
haven't touched on this yet, self-injury, self-harm is not suicidal ideation, right?
right.
Um, but I remember when I went to an event and this young lady, she was a young girl, she got up and it was a church event. And
Mhm.
she talked about having self-harmed and showed it to her parents.
Mhm.
Their reaction was like, "What?" They went crazy and all of this stuff.
Yeah.
And then she shared with the crowd was that when she got to the place of being suicidal, her parents were no longer an option.
Mm.
Um, and so, mind your reactions,
Yeah.
just in the sense of, man, we really have to have emotional intelligence, be calm through all things, so that we can continue the notion of trust between our family systems. And then lastly, as Dr. Golden point out, I think that we have to get support, right?
Yeah.
Not
Yes.
doing it by ourselves and elicit the support of friends, family, and mental health professionals. Yeah.
Thank you so much. And my last question for the panel, and I promise I'm going to give you the rest of your day back. But this is the topic. It's creating hope through action. So I think it's very important that we end with this question here. For those who are watching, there's a lot of information that they heard for the first time surrounding suicide, right? Parents, teens, whatever, right? We have a very wide audience here. Someone close to them comes to them and says they want to commit suicide. They are thinking about taking their life. What is one actionable step that a person can do, or say, however you want to phrase that, to that person who has come to them and confessed, I would like to take my life. And we'll go ahead and we'll start with you, Mr. Noble, and we'll work our way to end with Mr. Gaines, if that's okay.
Okay, when someone confides in you, the first thing is show empathy.
Okay.
Show empathy. Don't dismiss it. Don't look at them as if something's wrong with them.
Right.
Show empathy. Yeah. And that moment, have a conversation with them. Sometimes someone is coming to you to share, they just want to talk.
Yeah.
Let them talk. Let them talk. When they have spoken to you, now it helps you understand what the person is going through or have an idea of what the person is going through. You may
Yeah.
not be able to help at the moment, but
Right.
giving the person a listening ear is enough. Is a start. Is a good start. If you
Absolutely.
are a professional, if you're enlightened, you can refer the person to a professional. If you're
Right.
not a professional, but if you're a professional, you can take it up from there. Another thing you can do is once you've listened to the person, you need to take it up to the person's immediate environment, maybe the parents, a guardian,
Yeah.
or a loved one. Let someone close to the person know what's happening to this person so that they can get the love they need from every corner they find themselves. It shouldn't be them alone at that moment. So when people are aware, they
Hmm.
have support. So you help the person create a support system. The
Hmm.
support system help pull the individual out of that situation. Those are the few steps I think we can help, we can do to help.
Thank you so much, Mr. Noble. I appreciate that. Mr. Williams, what about you? Someone comes, someone's listening to this, and someone walks up, and they're not a mental health professional, not trained in anything around suicide. What is one actionable step that they can take to help that individual or to do something in action to prevent that suicide?
Yeah, certainly. I think my first question or the first thing that popped into my head was to breathe.
Yeah.
Um,
Yeah.
yeah, when we're met with a crisis, our prefrontal cortex is offline. We're not thinking rationally. So really, take a moment just to breathe, re-engage the brain, And then secondly, I would say understand what you can do and what you can't do, right?
I love that.
So maybe I can take you to the hospital, you can get assessed. Maybe I can call a friend that I know is available to really offer that support in a way that I cannot. So I think it really takes being honest with yourself and what you can do, and even sharing that with the person. I did want to just do one thing. I'm challenging myself to do a call to action, and I feel like this may be the last opportunity to speak.
Absolutely.
Um, but a recent study by the Satcher Health Leadership Institute between the years of 2016 and 2020 said that we lost 117,000 people to suicide. Yeah.
Wow.
The study goes on to just say that out of that these lives that we lost,
Yeah.
that there was $278 billion, right, lost across the world or United States and so forth. My call to action today is to the business leaders, to the clinicians. We have to put money into mental health, right?
Yes.
We'll have a lot of conversations and we'll uplift a lot of people, but if the resources are not there, we will not be successful. And so, thank you.
Absolutely. Thank you so much, Mr. Williams. I think that there's a lot of tape that comes when it comes to funding mental health that should not be there. And so you make a very, very good point about kind of making sure that we allocate those funds appropriately. Thank you. Dr. Bruce Golding, what is some actionable steps a person can take if they're presented with that type of news?
Yes, I would say, exactly what has been said before. Um, I'd also say thank you so much for telling me this.
Mm,
Thank
I
you
love
for
that.
sharing this. It's a simple thank you. And as you said, Dante, the importance of taking that deep breath and saying thank you for sharing this, because that person may have been carrying this for so long.
Yes.
And sometimes it is about us asking the question, but once they do share that, it's like, thank you so much for sharing this with me. And then depending on what you feel comfortable with, that's why I always go back to education.
Hmm.
If we're educated, psychoeducation, just being able to say, to tell me about your thoughts, just to see how far along they are with when it comes to their thoughts. Have they got something, the means to do what they say they're going to do, or are they thinking? So then, yeah, I think the first thing would be to say thank you, take that breath, say thank you, explore the thoughts a little bit, and then, yes, look at maybe we should go and see someone. But yeah, and working alongside that person to know that they are not this bad person for thinking this, that guilt that is built up, they've shared it. So that sharing of a problem or an issue can just be a lifesaver in itself.
Absolutely. And Doctor, I just love how you said the thank you piece. The research does show that the average person, before they actually say out loud, and it's rarely something that people will say before they do it, but the research does show that a person has thought about it over 50 times before they actually have the courage to say it out loud, that this is what they are getting ready to do. So that thankfulness and just letting them know that you appreciate them, at least being trusting you to express it, I think is very pivotal. So thank you for sharing that. And last but certainly not least, Mr. Gaines, what is an actionable step that a person can take when they're presented with that type of news?
I think that it's important to realize that in that moment you don't have to solve the problem.
Mm,
Mhm. Very.
We
Mhm.
and naturally, if a loved one or a friend comes to us and tells us this, we want to jump in and we want to figure out how to solve the problem, how to
yeah.
stop it.
Yes.
And that could actually work against us.
Mhm.
So we have to understand that it's more important to just be in that moment and just listen, be
Yes.
that present body to just listen. And then once you've heard, once you think them, you then just validate everything that they're feeling, everything that they just told you, everything that they just expressed to you. Provide that validation for them. And instead of you being the one to solve the problem for them, it's okay if you ask them, what do you need from me? What can I do to help you? Because they are the best person to let you know what it is that they need. So don't try to solve their problem for them.
Yeah.
Ask them directly, hey, what can I do to help?
Yes.
Because then that lets them know, like, hey, this person cares, this person is concerned, they're listening to me.
Yes.
Not them telling me what to do, not them telling me where I can go, what I need to do, what I need to say, how I should feel, but instead they are listening to what I am saying and they are asking how they can help. That is big right there. And then of course, there are organizations locally, nationally. In the United States, we have the 988 suicide hotline that people can call. So there are things that can be done when you are faced with a situation like that, once that person is ready to take those steps, though.
Absolutely wonderful. You are absolutely right. I think calling in and bringing in those resources and not trying to solve the problem, that is so important, especially for us, those who are parents or maybe have siblings. You want to help them, right? But sometimes the best thing that you can do in that situation is listen and point them in the right direction. Listen, you could have been anywhere in the world, panel, but you decided to be here with us, okay? And we are so thankful that you were able to share your experience and your enlightenment with us. I know that we went over time, and I do apologize, but I really believe that this time was spent very, very wisely and giving value to lots of people, those who are watching, those that will be listening. For those of you who are watching and listening to the show, if you would like to support Black Mental Health Matters, please head over to our website, bmhm.org, and there are multiple ways that you can support us. Panel, thank you again. Enjoy the rest of your days, and you will receive a follow-up from us via email. Thank you so much.